Good morning, all. I'm really speaking as an old obstetrician here, and just giving you sort of a little talk on some unusual warning signs in pregnancy and things that catch me out, and sometimes if they catch me out, they might catch you out. First one is itch. Itch is a really common symptom in pregnancy, particularly associated with striae, and abdominal itch is just a common symptom of a normal pregnancy. However, if a woman is complaining of itchy palms, itchy soles of her feet, not sleeping at night because of her itch, it is potentially more likely to be secondary to intrahepatic cholestasis of pregnancy. What that means practically is she needs liver function tests. Usually the transaminases are elevated, and you can actually now request bile salts. And bile salts, if they're elevated, is the sort of the confirmatory sign that the woman does have intrahepatic cholestasis of pregnancy. The reason that it's important is that it's associated with an increased fetal loss / stillbirth rate. And the overall relative risk for all cholestasis of pregnancy is a sort of 50% increase in the perinatal mortality rate. But if the bile salts are greater than 100, the stillbirth rate actually goes to 3.3%, which is actually quite high because the term stillbirth rate is actually 0.2%. So it's potentially quite a bad thing for a mother to have. What we do is we put them on ursodeoxycholic acid, UDCA, antihistamines, and generally do what obstetricians do, is induce them early. We have very few interventions in obstetrics. The other one I want to talk a little bit about is epigastric pain. And I've got caught out twice with this. A woman who turns up after Sunday lunch with mildly elevated blood pressure and severe abdominal pain. You're thinking, what's gone on to her GI tract? Another one turned up after a big feed of KFC. And they're a bit hypertensive, and the first thing you say is, oh, they must be in a lot of pain, it's put their blood pressure up. And then you get 4 pluses of proteinuria, then you get the abnormal liver function tests, and then the penny drops, and they're delivered within 24 hours because they've got fulminating preeclampsia. The interesting one, the lady who had the big feed turned up straight after her KFC, in actual fact, and on admission, her LFTs were still normal, but 6 hours later, they were actually quite deranged. The reason we mention it, though, is that it's a common symptom in pregnancy, and it's much more likely to be sort of a reflux esophagitis thing, and you all know that. But just beware of the fact that sometimes it's going to be fulminating preeclampsia. Dating scans, the reason this is up is just it's narrower at the bottom end and wider at the top. And essentially, the closer we get to conception, the more accurate our dating scans are. Because essentially the egg and the sperm are the same size for everybody. So it's only later in pregnancy that we get more likely to get the biological variation. And so this is the Ministry of Health ultrasound recommendations and their guidelines, and essentially we should use LMP dates unless the following sort of criteria. If we're more than 4 days out, under 10 weeks, more than 7 days between 10 and 20, more than 14 between 20 and 30. And once you start doing third trimester dating scans, you're getting out to 3 weeks. The only little proviso is if every now and again in a first trimester dating scan, we'll find that a fetal width has been measured. And the sonographer's looking there saying that shouldn't happen. And this is from my years of private practice. fetal width, well, not a crown rump length. They've gone across. And it's often a very quick scan, the cursory dating scan, and the sonographers actually measured not the length of the fetal pole, but the width of the fetal pole. And you've got this early scan that everybody tells you should be the most accurate, and when it's done properly, it is the most accurate. But if somebody's actually measured it wrong, it won't be the most accurate. The other thing is, to talk about the poxes, syphilis is back, and I just had not seen a case. I'd heard about it when I started in 1990 through to 2019, when I'd given up private practice with doing locums. And first, if one was a sore, I'll show you a little picture in a minute, but the guy was wandering around Gisborne with his shirt off, with a secondary syphilitic rash proudly displayed. Only in the provinces. Wouldn't see that in South Auckland. Anyway, look, 50 to 75 reproductive age women a year get syphilis. Not all of them are pregnant. Not all of it gets through to the fetus, but unfortunately we're seeing 4 to 6 cases of congenital syphilis per year. It remains a very treatable and preventable condition. Down the bottom, do I have a pointer? I do. This is my lifetime, sort of was reflected. It goes back at 0, way back over here somewhere. But in recent years, you can see that this, running through here, thank you, little green button at the top. Oops, that didn't work very well at all, did it? Try the green button, Derek. This is women who have sex with men. Sorry, I thought it was with women. No, women who have sex with men has just come up over the recent years, and it really was for years sitting down here around 0. The very interesting thing, I just looked this up yesterday. Men who have sex with men have a higher educational achievements and are more health literate than general heterosexual men and the general population. And they get the message. And so essentially this is the men who have sex with men have got the syphilis message, and it's declining nicely. But unfortunately, in our sort of heterosexual males and our women who have heterosexual women, we've just got a fairly slow but steady sort of increase. And this is the sort of rash that I thought saw in Gisborne. The other thing too is the primary chancre is usually hidden in women. It's often vaginal, so you're not going to see the primary. And the key message really is to refer to sexual health, and it's a long-acting penicillin, and one of the couple of cases I've seen, the initial treatment was with the inappropriate short-acting penicillin. So essentially the easy answer is to refer to sexual health. The other pox, chicken pox, fetal varicella syndrome, can affect the fetal eyes, brains, limbs and skin. Vertical transmission rate is greater than the actual fetal infection. Most of the fetal infections will occur sort of early mid-trimester, basically not in the 3rd trimester. And we have the option of zoster immune globulin, which for the non-immune mother who's been exposed to chickenpox, it can be up to 10 days post-exposure. And essentially, the research supports, ZIG zeroing fetal varicella syndrome. Essentially, if the mother has got chickenpox, it's too late for ZIG, but the antivirals actually are okay in pregnancy. And you refer through to maternal fetal medicine. I'll do a little quick. And we need, in fetal medicine, need to scan them at least 5 weeks because it takes time for the changes to develop. Amniocentesis is very good at excluding it if we do a PCR for zoster. And this is one big series, basically just basically shows the transmission rate. 9 out of 107 amnios were actually positive, but only 2 of the 9 actually had varicella syndrome. and there was somebody terminated anyway, one had triploidy, and they got 5 healthy babies. That's my bit. May's turn.
So my fast and furious bit is about blood pressure and thyroid diseases. If we look at the target blood pressures over the years, you will see that there has been a downward trend for the target to treat. And compared to the 2014 SOMAN's guidelines, the targets are now systolic below 140 and diastolic below 90 in pregnancy. In any hypertensive young person with childbearing potential, it is probably best to avoid an ACE or ARB unless there are extenuating circumstances such as heart failure or proteinuria. Pregnancy-friendly medications to optimize blood pressure control include labetalol and nifedipine, which are far more friendly to the woman compared to methyl-dopa, which is rife with side effects of headaches and somnolence. Always consider secondary causes for hypertension and check to see if the woman has been previously investigated. When hypertension is quantified in early pregnancy, please remember to instigate or escalate medical therapy to targets, especially if her blood pressure is above 140 or above 90. Along with the first antenatal bloods, please also include renal function tests and consider a baseline urine protein creatinine ratio. Please add aspirin, calcium, and perhaps some vitamin D to facilitate calcium absorption as early as possible. This will help attenuate the risk of placental insufficiency. In a normal pregnancy physiology, blood pressure falls as systemic vascular resistance falls in early pregnancy, and this results in a spurious improvement in the renal function and reduction in proteinuria. However, this does not mean that their kidney problems go away or blood pressure goes away. The pseudo-normalization of a hypertensive pregnant person means that adjustment of blood pressure medications is necessary, and this tends to be a short-lived period, and it's a matter of time before the blood pressure rises again. There are a plethora of medications that can be used in pregnancy, and the doses can be optimized. Labetalol is best prescribed at least twice a day, but better 4 times a day. There are a few points about postpartum hypertension. Please avoid non-steroidal anti-inflammatories as pain relief. If the woman has had preeclampsia during pregnancy, then titration of antihypertensives is best done slowly with the same targets as the general population. If she's had proteinuria in pregnancy, please requantify to ensure that it resolves completely, or she may need a referral on for further investigations. If the woman has persistent hypertension, sometimes secondary causes will also need to be excluded. Now, in any person with thyroid disorders, they should be assessed prior to pregnancy if possible. However, universal testing of TSH and free T4 is not recommended. The following are those in whom TFTs would be quite useful in early pregnancy. The fetus is dependent on maternal free T4, which is then converted to free T3 by placental deiodination. And this is used for fetal neurodevelopment. The general teaching has been to aim for a TSH of less than 2.5, but we know that in those who take their thyroxine less than regularly, the free T4 may be normal, but they will continue to have a raised TSH. So my practice really is to aim for a free T4 at the upper limit of normal, especially in the first half of the pregnancy. And for that reason, please also include free T4s when you're checking TSH levels. Empirically increase the pregnant person's thyroxine dose if they're hypothyroid by 25 to 30%, even though they're quantified to be euthyroid at the start of pregnancy. This is because of the demands of thyroxine are more, particularly in the first trimester. And please recheck thyroid function tests 4 to 6 weekly after any dose change. These are the updated trimester-specific ranges that have been in discussion. The current ranges on the health pathways are the bigger numbers, and those in brackets are the newer proposed ranges. The current health pathways doesn't actually include target TSH, which is a little bit unusual, as you find that quantified far more often than free T4. Another point that you will see here as well is that the free T4 is much lower in later pregnancy. And in some pregnant persons, we find that isolated free T4s in the third trimester are perfectly normal and no treatment is required unless they have a concurrent raised TSH or symptoms. The most common cause of hyperthyroidism is Graves', and if possible, control the thyrotoxicosis before coming off contraception. Swap to PTU pre-pregnancy or in very early pregnancy, but then swap back to carbimazole after 12 weeks. The reason is there is a very small risk of liver failure in pregnancy from PTU, and this is an idiosyncratic reaction, so it can occur at any time regardless of duration of use. In anyone with Graves' or a doubt as to the etiology of their thyroid disease, please consider adding TSH receptor antibodies to their early bloods, because raised TSH receptor antibodies do have clinical implications on the neonate. And these levels fall quite rapidly as the pregnancy progresses, and sometimes after 20 weeks they may no longer be present. TSH receptor antibodies are also particularly useful for differentiating between biochemical thyrotoxicosis of hyperemesis in pregnancy. And with hypothyroidism, recheck free T4 and TSH 4 to 6 weekly after any dose change. Thank you.
So I was wanting to just very quickly introduce you or reintroduce you to the weight change in pregnancy cards. Those of you that work in counties should have seen them in the pregnancy packs, and those that don't work in counties, you can get to them on health pathways. So what we're talking about is healthy weight gain in pregnancy, and we know that this is a huge problem. I think the diabetes in pregnancy talk helped to point some of the complications from excessive weight gain in pregnancy. I would just encourage you to have these conversations with women, because we know that if people don't talk about this, then people think it's not important. And so it's really important to raise these topics and have the conversations. And you can see on the card, on the back of the card, which is on your left-hand side, it tells women why it's important. And on the right-hand side of the card, it gives you 4 simple things that you can do to make a difference. And that's watch your portion sizes, drink water, eat lots of colourful vegetables, and do some activity every day. Nice, simple messages. And this is the bit that we're wanting you to do. So if you've worked out the BMI of the woman, you can see which graph she should follow. So the weight gain in pregnancy is according to the starting weight, so according to her BMI to start with. What you do is you put her weight at the time that you've taken it as the top of the box on top of the graph. Now, if I can use the pointer. So up there, on each graph, the initial weight, and then you put a mark on the blue line down here of the number of weeks she was when you took that weight. Now, everybody wants to try and put a weight on the graph when you start, but you don't need to do that. You just mark when you took that weight. And every weight you do after that is a plus and a minus from that starting point. And the idea is that as she goes through her pregnancy, her weight should stay within those lines. If she's going above the red line, then she knows she can see what's happening, and it gives her some immediate feedback to where to go. Okay, hope you'll all be using these cards. Thank you.
So I'm going to talk about headaches, vaccinations, vitamin D, and anaemia. So starting with headaches, as you'll know, there's a lot of headaches in the community, and pregnancy is not protective against headaches. So if someone has headaches and sees you for them or has treatment when they're non-pregnant, then they're going to continue when they are pregnant. And they may be exacerbated by first trimester symptoms of nausea, vomiting, making them dehydrated. So if someone's regularly on some, say, non-steroidals, then it's good to warn them that they need to stop those non-steroidals if they do become pregnant. And otherwise just have a talk with them about what their plan might be when they do become pregnant. So the key point for investigating and looking at new onset headaches is to remember your red flags. If this is a sudden onset of a headache, then just like a non-pregnant person, we need to be investigating headaches or investigating the pregnant woman as we would the non-pregnant woman. And this is something that isn't just for headaches, heart problems, chest pain, all sorts of things. In pregnancy, we must remember that pregnant women can get all the illnesses and problems that non-pregnant people do as well. So there are some things that happen more in pregnancy than out of pregnancy. So if someone has a headache and you need to exclude preeclampsia, so just like the epigastric pain, a headache can also be a presenting feature of preeclampsia. So you need to be excluding hypertension, proteinuria, and checking renal function and referring to obstetrics if you're worried at all. And that goes through to the postnatal period when women can still have seizures and complications of preeclampsia. We also have women at risk of clots in pregnancy, and so we see relatively, often cerebral venous thrombosis, which is presenting with a severe headache. So really important that we refer for the investigations. A CT or an MRI, far more useful than missing something going on in a head. So just talk a little bit about the medications that are used for headaches and migraines that you may be asked about by your pregnant woman. A lot of women will stop all medications as soon as they get pregnant, and we do need them to continue with them and know that they're safe. So a low-dose aspirin as prophylaxis against headaches is a good way to start. Paracetamol is safe, up to 4 grams a day, but as we've said, avoiding non-steroidals in the first trimester, and then again after 32 weeks because of the fetal risks of oligohydramnios and premature closure of the ductus, which we've spoken about. So best not to use frequently, but as a one-off meaning that they get a good night's sleep, or so up to 3 times a week is all right. Other medications that can be used for headaches in pregnancy are codeine. It's good for short-term use. It does have the side effect of constipation, and best avoided in breastfeeding. Babies can get respiratory depression with fast metabolizing of the codeine, so best not to be taking it then. Other opioids, tramadol, oxycodone, best avoided in the 3rd trimester as well. Some women do need to continue with tramadol, not necessarily for headache, but other chronic pain conditions. And so we're able to enlist the help of maybe the pain team or anaesthetists at the hospital, and also make a neonatal plan for babies if there's a risk of neonatal abstinence for them. Next page. So migraines, women might be on amitriptyline, but if they're not, it's a really safe medication to take in pregnancy. We've used it for a long time, and a low dose that starts maybe from 10 milligrams up to 25. They need to take it regularly, and as you know, it doesn't kick in immediately. They may get the side effects of sedation and a dry mouth, in which case nortriptyline may be a better alternative. Those of your patients who have been on triptans will be nervous about keeping them going in pregnancy as well, but they are safe to take, and taking them appropriately as the migraine starts is much better than ending up with a severe migraine. But best avoided if the woman has preeclampsia or hypertension. And the other one is low-dose beta blockers, propranolol or metoprolol, just at 23.75 milligrams, is good as a prophylaxis as well. There is a sort of slight risk of SGA with higher doses of beta blockers, so growth restriction of the babies, but with the low doses that you can use for prophylaxis, there's no concerns about that. Just have to make sure that the mother is not becoming hypotensive herself. Can you hear me all right at the back? Yep, great. Okay, so just a quick word on vaccinations. Excuse me. Back in 2009 with the H1N1 epidemic, there were 5 maternal deaths in New Zealand from influenza. And when you think that that's the first year in some time that we had more than 10 maternal deaths altogether in 1 year, usually they're sitting 8, 9, maybe even less. So losing 5 mothers from influenza is quite a dramatic number. So following that year and those deaths, that was when the Ministry of Health decided to make influenza vaccination free for pregnant women. And it's something that's really important for us to be recommending to women. So being pregnant makes hospitalisation with influenza up to 5 times more likely than not being pregnant. And having flu in your pregnancy can affect your baby. You've got increased risk of being premature, being small for gestational age, and of the baby ending up in the neonatal intensive care unit. So a flu vaccine can help protect both the mother and the baby from adverse outcomes. It's free, it's safe, and you can offer it throughout pregnancy, as you can for a COVID vaccine, which I'm sure you all know well about, and I won't dwell on that, but the other one is whooping cough. It can be offered from 16 weeks and protects both the baby and protects the main reason for it is to protect the baby rather than the mother. The baby's first immunisation is at 6 weeks of age, and you're getting a 90% protection for your baby by immunising your mother. So once again, they're free, they're safe, and after 16 weeks for the whooping cough. But all can be given together. I'm not sure that many women would want 3 injections on one day, but they can be given together. So moving on, vitamin D. We've had a bit of a talk from Chris about this, and the main reason for replacing vitamin D in mothers is to make sure that neonatal levels are high. But there's also a theoretical risk of reduction of preeclampsia with vitamin D supplementation in mothers. So those that are at risk, the darker skinned women, the women who are avoiding sun for medical or cultural reasons, women who are obese or who have had bariatric surgery. It's not routine to test, it's not very cost effective, so treating them with risk factors is the way to go. 1.25 milligrams of cholecalciferol monthly, and if you do know that they're deficient, then a 10-day loading dose followed by the monthly treatment is fine as well, and continuing that through breastfeeding, as Chris spoke about. So finally, anaemia. Iron deficiency anemia is something that we see a lot in counties Manukau, and we've worked quite hard to try and improve that for our women. They're coming into pregnancy often already quite iron deficient from a previous pregnancy, from the menorrhagia that you've heard about earlier this morning. And the maternal effects of chronic anemia, I'm sure you all know well. Not only fatigue and poor sleep, depression, reduced immunity and cognitive impairment. So it's really important to try and take the opportunity of when you're seeing women in pregnancy to try and increase their or reduce their iron deficiency anemia. Chris has talked to us about the neonatal effects as well. And what we have started doing, and in fact managed to get onto our blood forms in counties, is ferritin with the booking bloods and with the subsequent bloods. So it's not a national recommendation, it's not even used throughout Auckland, but it's just an ongoing reminder for all of us about midwives, doctors, about how important the iron is and getting them onto treatment early. So diet is never going to be enough to replace your iron when you're pregnant. And so if you're starting pregnancy with low iron or even borderline iron, you're going to need some iron supplementation. Also education around when the best way to absorb your iron is, so knowing that red meat's got the most iron in it, there's much less in your vegetables. And avoiding tea and coffee with your meals is really important to improve or maximise your iron absorption from your diet. Supplementation, there's new evidence that actually taking an iron pill every second day is just as effective as taking it every day. And I think that's great news because so many women have side effects from taking an iron tablet every day or even being given it twice a day and really getting quite badly constipated, not being able to tolerate the tablets at all. So they're best taken on an empty stomach and with some vitamin C to maximise absorption. Take them well clear of tea, milk, cereals, antacids and anticonvulsants, and continue them through into the postpartum period when mum's breastfeeding and needing that extra energy as well. We're lucky to have had POAC-funded Pharinject, which we use a lot for women who maybe are not responding to oral iron, presenting at later gestations or with more severe anaemia, but you can get a really good response to oral iron and it's way cheaper than the Pharinject if you can get going on it and just take it from earlier in the pregnancy rather than waiting until your ferritin drops below 6. So finally, thalassemia is another reason that someone might be anemic. Most women who we see will either have an alpha or a beta trait and just have mild anemia, but it's really important that their partner is tested and either with a full blood count, if it's very normal then they're probably fine, but also possibly a hemoglobinopathy screen, and then referral to the MFM team for consult if both parents are affected. These women shouldn't be having intravenous iron, and occasionally they'll become so anemic with hemoglobins less than 80, say, or 70, and symptomatic that they're going to require transfusion. That's it from me. Thanks to May for her help with my presentation, and open the floor to questions.